introducing some definitions that will keep coming up as we go along. One is alcohol use, simply defined as ingestion of a drink containing alcohol. We know alcohol is a hydrocarbon produced by fermentation of carbohydrates. And another term we shall find along the way is alcohol misuse, which is ingestion of alcohol that is higher than the lower risk limits. And we had an operational definition of subjects who scored on our examining tool of 3 or more points. Another term is hazardous alcohol use, which we define as a pattern of alcohol use that increases the risk of harmful consequences. And we also had the cutoff points of 8 or more on the audits. This audit is an internationally validated tool to screen alcohol use disorders in primary settings, and it has a score range of 0 to 40, and the higher the score, the higher the likelihood of alcohol use disorder. We also had a definition for alcohol dependence, but as you'll notice, we did not use that a lot. We know that this slide here is depicting the distribution of alcohol consumption in 2015 globally, and we see that the darker colors represent countries that consume higher alcohol, while the lighter colors represent a less alcohol consumption. And we know globally 38% of the world reports consuming alcohol at least once within the last 1 year. And the average alcohol consumption per capita is about 6.18 liters. When you see the countries in sub-Saharan Africa, we see the colors are darker. And when you look at the key, this represents at least above 8.5 liters of pure alcohol per year. So we are in a region where alcohol use is higher than the global average. And in Uganda, the prevalence of alcohol use is about 47%. And on average, each adult consumes about 10 liters in a year of pure alcohol. Of course, males take more than females, and we are ranked 9th in Africa in terms of alcohol consumption. We produce alcohol through commercial and homemade alcohol, although the majority of alcohol consumed is homemade. Still in sub-Saharan Africa, we are in a setting where there is high HIV prevalence. This figure is very common to most of us, and we see that sub-Saharan Africa contributes to more than 2/3 of the global HIV prevalence. And in the key there, we see that more than 8 countries contribute. 8 countries have an HIV prevalence that's more than 10%. And the next dark color we see there, Uganda, has an HIV prevalence of between 5 to 10%. And in sub-Saharan Africa, we know that the majority of HIV is transmitted through a heterosexual route, and alcohol use among people who are with HIV has been demonstrated to people who are HIV infected have been shown to have people who are HIV infected and use alcohol have been shown to report poor adherence to their medication, to report multiple sex partners, unprotected sex, and transactional sex. And in this alcohol consumption, there's also a reduction in adherence. And Kalichman has demonstrated that people who are HIV infected and on ART were more likely to have a high plasma viral load. And here you are in a setting with high plasma viral load, high plasma viral load, and more likelihood of engaging in risky sexual behavior, which makes onward transmission of HIV very likely. And in Uganda, we know that more than 1.5 million people are infected with HIV, and this is slightly old data. About 60% or more of the population of the HIV-infected people are receiving ART. We also know that alcohol contributes a lot to the global burden of disease and injury, and has been associated with an increase in the incidence of HIV and infectious diseases. And as work has shown that alcohol adversely affects the cause of HIV. I've alluded to that alcohol increases risky sexual behaviors, and a number of hypotheses have been postulated that could lead to this, in that alcohol tend to create a bias in attention to those salient situational cues, which if a person was sober, it would elicit them to not engage in sexual behavior, or in for that matter, risky sexual behavior, but in the presence of alcohol, these situational cues are not elicited. But we also know that for certain parts of a population, the mere belief that they've taken alcohol, there is that expected effect of them engaging in sexual behavior. And also certain personality predisposes people to drinking alcohol and engaging in risky sexual behavior. I also alluded to how people who are living with HIV who use alcohol may have faster HIV disease progression, and there's been epidemiological work that has demonstrated that heavy alcohol users who are not on ART had lower CD4 cell counts compared to persons who are not using alcohol. And BAM also showed that subjects who are using alcohol had 3 times the odds of reaching the CD4 cell count of less than 200 compared to non-users. However, there's also some work that appears to show that they could actually, alcohol may not have an effect on HIV disease progression. And the mechanism in which alcohol accelerates disease progression, one is due to, because people who take alcohol may decrease their engagement in HIV care, they reduce their medication adherence, and they also, and therefore the effectiveness of ART would be impaired. But also the biological mechanism means that alcohol in vitro studies have shown that alcohol is associated with increase in immune activation, and in the setting of HIV viral load, in the setting of HIV, this immune activation is associated with increased viral replication. But also the fact that a big bulk of alcohol is metabolized in the liver, and so developing metabolism of alcohol and ART in the cytochrome P450 system might affect the bioavailability of ARVs, hence leading to faster disease progression. So what is the problem? We're in a setting of dual occurrence of HIV and alcohol and high alcohol use. Yet this problem is not well described in settings like Uganda. And also whether alcohol affects immunological response among people who are in care is not known. There is no data to show that. The little data was available from small samples, and the alcohol was assessed in ad hoc. Do you take alcohol? Yes and no. And most of these studies were cross-sectional. And so those are some of the limitations. And in addition, we do not know currently whether alcohol use, in fact, in this population affects immunological response to ART, and there are also a few studies that have tested interventions to reduce this alcohol use among persons who are living with HIV. We think if we can gain insights into that, we shall have an we shall be able to collect information to design appropriate alcohol reduction interventions. And also when we identify other behaviors that people who use alcohol exhibit, it helps us in incorporating those other behaviors in designing a comprehensive intervention. And also in terms of advancing knowledge, because I showed you conflicting information about alcohol and CD4, so rather an immunological response. Another justification for our study is that we need to gain an understanding of what are the mechanisms that underlie behavior change from drinking alcohol to not drinking alcohol. And so we designed a tool to try and assess this. So we explore factors that are associated with alcohol use, its effect on the effect of alcohol use on immunological response, and design an intervention to reduce alcohol misuse, if you remember from the definition, among people living with HIV. And specifically, we aim to estimate the prevalence of alcohol use and test whether alcohol misuse was associated with risky sexual behaviors. We determined whether hazardous alcohol use we determined whether hazardous alcohol use was associated with lower CD4 cell counts, and we tested an efficacy of a brief motivation intervention counseling on reducing alcohol use among people infected with HIV. And lastly, we assessed the reliability, validity, and factor structure of the stages of change readiness and treatment eagerness scale in assessing readiness to change alcohol use among people living with HIV. And so this, you'll excuse me, this pointer doesn't work on this screen, but we know that consumption of alcohol, I've alluded to, is associated with the risky sexual behaviors, and I've also briefly hinted about its effect on reduction in reduction in ART adherence. And this would be the alcohol, of course, varies by volume, frequency, and the duration of consumption. And there are individual factors that would affect this interaction of alcohol and engaging in risky sexual behaviors. But I've also alluded to how alcohol would result in lower CD4 cell count, either through its effect on increasing viral replication or reduction in adherence, and then, but there is also a postulation about the direct effect of alcohol on CD4 cell counts. So if we design an intervention, we'll be able to reduce these subsequent effects. So we ended up designing an intervention to reduce alcohol use. And our objective one tackles that issues around alcohol and risky sexual behaviors, and objective two is looking at the interaction of alcohol and CD4 cell counts. Objective three is testing an intervention to reduce alcohol use among HIV-infected persons, and objective four takes an in-depth understanding about motivation to reduce alcohol use. And this, we designed 4 independent studies at the IDI, 2 cross-sectional studies, 1 cohort and 1 randomized trial. For all studies, we enrolled subjects who are aged 18 and above, who provided informed consent. We obtained relevant approvals. As you'll notice, audit comes back again. The alcohol use disorder identification tool was the main tool for assessing alcohol use. However, we had also a timeline follow-back approach to assess alcohol use, and we also assessed sexual history in the past 6 months. CD4 data was abstracted from clinical records, and our data was double entered and analyzed in SAS. So to give you an idea about the setting, the HIV clinic is a public, the study setting was a public HIV clinic that provides comprehensive care to adults and adolescents living with HIV, and it also provides routine group and individual positive prevention counseling to new patients and whenever needed. And there has been no alcohol interventions in this setting. So briefly, I say the clinic provides positive prevention counseling, and it tackles the 3 key areas of keeping persons living with HIV physically healthy, mentally healthy, and also tackles issues of preventing onward transmission of HIV. So this slide here is very busy, but it just gives a summary of the 4 studies, the numbers that were involved, and the statistical methods that were used. However, I'm going to repeat them as we go along. So our objective one was to estimate the prevalence of alcohol use and test whether it's associated, whether alcohol misuse was associated with the risky sexual behaviors. And we published this paper in PLOS ONE. We enrolled 725 subjects who we assessed their sexual history within the past 6 months, as well as alcohol use within the past 6 months using audit. What is audit? Audit, I told you, is an internationally validated tool to screen for alcohol use disorder. Its advantages is that it enables rapid administration, non-invasive, and it's inexpensive. It has been validated for settings including Sub-Saharan Africa. And its components, the first, it's a 10-item tool, and its first 3 questions that tackle mainly consumption can be used to assess for alcohol misuse. This slide is very busy, but gives you a feel of what the questions are. For example, when you go to question number 1, how often do you have a drink containing alcohol? And down there, the options: never, less than monthly, monthly, weekly, or daily, almost daily. And these scores, these responses had scores of 0 to 4. So the total score of the tool is 40 points. The higher the score, the higher the likelihood of an alcohol use disorder. So our goal was to estimate alcohol use outcomes, that is alcohol use, alcohol misuse, and hazardous alcohol use, and its association with risky sexual behaviors. We used multivariable log binomial regression models. On this slide, I just want you to have a feel of the population. In the bold, in that we, of the 725 subjects enrolled, 2/3 were female, which is not uncommon among HIV. Rather, not 62% were female, which is not uncommon among HIV populations in these settings. And the median age was 39 years, and 82% of the population was receiving ART at the time of the study. So what did we find? Of the 725 persons enrolled, 239, which is exactly a third, reported using alcohol at least once in the last 6 months. And when we scored them on the audit C tool, which was the first 3 questions of how often do you have a drink containing alcohol, the approximate amounts of alcohol you take, and then how often do you take 6 or more drinks, we see that more than half of those who are using alcohol fulfill the criteria of alcohol misuse, which is scoring 3 or more points on the audit, while those who fulfill the criteria of hazardous alcohol use were about 16%. So this slide, I stratified the alcohol use outcomes by gender. You have to believe me if you're a believer. All these were different by gender. I did not want to crowd the slide by including p-values. What we noticed is that the proportion of males who reported any alcohol use outcomes were higher than that of females. That's for any of the outcomes. Alcohol use, alcohol misuse, hazardous alcohol use. So what were the factors associated with alcohol misuse? In the second column here, persons who reported alcohol misuse were more likely to not have been on ART. We see a prevalence ratio of 1.65, and they're also more likely to be non-adherent to medication. Another point to consider, subjects who had alcohol misuse were Pentecostal, Muslim, or Adventist were almost 90. Their prevalence of reporting alcohol use was 90% less compared to those who are Anglican. And I made this categorization based on the overt emphasis of certain religious sects on prohibition of alcohol. So among females, we see that alcohol misuse the prevalence of alcohol misuse was 80% higher in subjects who still were not on ART, and the older the female, the less likely they were to report alcohol use. And also here, being Pentecostal or Muslim was protective against reporting alcohol misuse. And females who had alcohol misuse were more likely to report non-adherence to medications, and they were also less likely to have depression, which was an incidental finding that we're still trying to explore. So our other hypothesis was to test whether alcohol misuse was associated with risky sexual behavior. And in this slide here, we see that among males, the prevalence of alcohol misuse in subjects, rather the prevalence of reporting risky sexual behavior was 67% higher in those who reported alcohol misuse compared to those who did not have alcohol misuse. And similarly, among females, this was slightly less, and we noticed that in females it wasn't statistically significant. But generally, subjects who reported risky sexual behaviors were also likely to not have disclosed their HIV status to their sexual partners, and also likely to be non-adherent to medications. All those values, they are statistically significant in both genders. So in summary, 1 in 3 of persons living with HIV using alcohol, rather 1 in 3 of persons living with HIV were taking alcohol, and the participants with alcohol misuse had a constellation of other negative behaviors that I've described elsewhere to negatively impact ART success. I have told you medication non-adherence and risky sexual behaviors and non-disclosure of HIV serostatus. Participants with risky sexual behaviors may be candidates for brief counseling therapy. So we see that people who use alcohol are more likely to engage in risky sexual behaviors, more likely not to disclose, which is bad. But would this alcohol use have an impact on one of the goals of ART, which is restoring immune function? So with this, our second study, which was a cohort study, tried to answer this question. And this paper was accepted in +1 for publication, although it's not yet out. And we designed a prospective cohort study where the exposure in this case was hazardous alcohol use, which we defined as initially subjects who we assess the alcohol use and classify them as either hazardous, non-hazardous, or non-alcohol use based on the score they had in the audit. So this is what I was trying to describe with my hands, and we obtained their CD4 cell counts at enrollment and then followed them up for 12 months and obtaining their CD4 cell counts. So we enrolled 1,566 participants, and 17% were classified as exposed in that they fulfill the criteria for hazardous alcohol use. And hazardous alcohol users were more likely to be males with a shorter duration of HIV and more likely to be non-adherent to medication, which is slightly similar to what we saw in Objective 1. This is just the same data presented differently. So what happened at baseline? At baseline, the CD4 cell counts of subjects who are hazardous alcohol users or non-hazardous alcohol users was not different. We very well know that ART has a big influence on CD4. So we analyzed our data separately by ART strata. So here we can see among non-ART, the box and these plots show that there is no difference in the median CD4 cell count, whether you're on ART or not on ART. And this is baseline CD4 cell count. And over time, these two figures try to show how the CD4 is changed by the 3 strata of hazardous alcohol use. And generally, there is the eyes can give you a clue, but when you go to the numbers, we analyzed our data using linear mixed effects regression because we obtained repeated CD4 cell counts from the same subjects. So we analyzed we accounted for the repeated measures of these CD4s in each subject. One point I want to mention is that we are interested in group differences, in that our outcome here was the mean CD4 in a group over time. The natural one would be to do group by time interaction, which we thought would not give us the answer that we wanted. Rather, we thought it was easier to explain this way based on the target population that we wanted to address, to which our clinicians. It was easier to explain the data this way. But what we see is that over 12 months, among subjects who are not on ART, there is no difference in CD4 cell counts. Our outcome here, you see there in the boxes, mean square root CD4 cell count, because we had to adjust for. Rather, we had to these were linear models, so we had to transform the data. But there was no difference in CD4 cell count by hazardous alcohol use category. Our second objective was to look at CD4%. They were also not different by hazardous alcohol use category. But we see time is significant there because CD4 changed over time. Still, even among subjects who are receiving ART, the second row, we see that there was CD4 cell counts over 12 months was not different among hazardous alcohol users compared to non-hazardous alcohol users. Of course, this was a cohort study. We adjusted for very many variables, and I listed them down there, include adherence, depression score, the baseline CD4 cell count scores, where we start with you and we go along matters, and also the duration in which you had lived with HIV, because the duration of HIV is a predictor of your CD4 cell count. So we see that hazardous alcohol use within the past 6 months was not associated with lower CD4 cell counts at baseline and over the next 12 months. In our secondary analysis, although we did not have enough samples, there was a likelihood that subjects who are non-hazardous alcohol users and had poor adherence, these subjects had lower CD4 cell counts. However, I did not present that data because we were still trying to tease out the nitty-gritty. One thing that I came across would be, I showed quickly the types of alcohol that subjects consume. 90% reported taking beers, and 4% reported taking spirits. Recent work appears to suggest that spirits may have more impact on CD4 because of their direct effect on reducing thymus size, which we know is responsible for the new generation of CD4 T cells. So we know that hazardous alcohol use is not associated with CD4 cell counts, but people who are infected with HIV and hazardous alcohol use wasn't associated with reduced CD4 cell counts, but alcohol use was still high, and a significant proportion was taking alcohol up to hazardous levels. And alcohol use was also associated with behaviors that we said impact HIV treatment outcomes. Interventions could reduce these effects. However, the ones that have been tested are from high-income countries. The few tested from Sub-Saharan Africa, one from Eldoret, used followed up subjects over 12 months, used cognitive behavioral therapy, and followed up subjects over 12 months and gave 6 repeated sessions, and the intervention was effective. However, you can imagine seeing subjects every month, the implementation of that would be harder. And other trials were not as effective, except some in TB subjects in South Africa. So at the moment, there was no evidence that an intervention for HIV-infected persons would be effective in this setting. The one that was effective, it had multiple visits, and we thought if we're trying to scale up this, it's almost impossible to have people coming to the clinic monthly, yet we're trying to make people live longer away from the clinic. So there was a need to test an intervention. We know that alcohol use can be managed through behavior treatments, medications, and mutual support groups, and this can be given individually or in combination. So our objective 3 was to test the efficacy of a brief motivation intervention session in reducing alcohol use among people who are infected with HIV, and we are not seeking care for their alcohol use. And we hypothesized that adding a single brief motivation intervention session onto the standard positive prevention counseling, I alluded to in the beginning, would result in greater reductions in alcohol use over 6 months compared with only the standard counseling that's provided in the clinic. And this was a 2-arm randomized trial with parallel design. We enrolled subjects who had alcohol misuse, that is a score of 3 or more, and there has been no systematic alcohol assessments done, rather alcohol interventions at this clinic. So we carried out audit C assessments at baseline, 3 months and 6 months. And we compared the changes in audit C scores over these 6 months of follow-up. And we used univariable and multivariable linear mixed effects regression models. And what were the interventions? The control arm, which I alluded to, was the standard positive prevention counseling provided in the clinic, and the intervention was based on motivation. The intervention was, subjects in the intervention arm received the standard of care plus a 10 to 15 minutes counseling session based on motivation interviewing style, which is a directive, client-centered counseling approach that elicits pros and cons of taking alcohol with the aim of correcting the ambivalence that the subject might have in reducing their alcohol. In that, the counselor's goal mainly is to elicit from the subject within themselves resources so that they can reduce their alcohol use. And so most of the time the counselor uses reflective listening and inquires about the plans the subject has about reducing alcohol. The total duration of the counseling was 30 minutes, although the intervention arm was slightly longer than the control arm. But these were provided by 2 different counselors that were in 2 different separate places. So the trial profile, we enrolled 342 subjects. What is important here that we did not, what I want you to note is that we had most of our subjects available at the last follow-up visit, which was our primary outcome. Less than 10% lost to follow-up. I will assure you, and you want to believe me, that the groups were balanced on most parameters, actually on most parameters that were available. So our randomization worked, except on one that I'm going to allude to. So our primary outcome, the mean audit C scores, this is what happened over the 6 months. One, the scores reduced, and I told you the lower the scores, the lower the likelihood that the lower the alcohol you're taking. So over 6 months, alcohol use decreased. But we see obviously the reduction is not different, because the reduction is not different by group. And we see that within the first 3 months there was more reduction than in the next 3 months. One important point here, you see that the intervention arm scores are slightly higher than the control arm scores. That is the point I said, the exception in our randomization. So because we had these two audit C scores, when we accounted for those 2 scores in the analysis, this is what we found. The first row shows that the mean change in audit C score was not different, whether you received the standard positive prevention counseling or whether we added on motivation intervention counseling. So the mean change in audit C score was less than even 1 point. The audit C scores are in 1, 2, 3 points, so there was minimal change. However, when we stratified our analysis by gender, there appeared to be an effect among females, in that females who received the intervention had a mean score of 1.1 less compared to those who received the control. And this was statistically significant. And in all these models, we adjusted for baseline CD4 count, audit score, and then the random intercept for each subject, because we allowed each subject to vary. We allowed each subject's audit C score to vary over time. So there were marked reductions in alcohol use in both treatment arms, and greater reduction in the first 3 months compared to the next 3 months. And adding a brief motivation intervention did not result in a statistically significant reduction in alcohol misuse, although there was a significant effect among female participants only. So the problem could be probably not lack of effect of our intervention, but the fact that the control group was in and of itself effective. It had enough ingredients of change. If you remember the three domains of interventions that the counselors provide. We should also appreciate that for each interview at baseline 3 and 6 months, patients reflect on their alcohol use, and this provides a teachable moment, the so-called assessment reactivity. So just by the interview alone, subjects could reduce their alcohol use. The alternative would have been to probably have a no intervention at all, a no intervention arm, but this will be unethical, because I classify these subjects as having alcohol misuse. So in the interim, we think of providing the standard positive prevention counseling structured at periods not exceeding 3 months could be undertaken for subjects who have alcohol misuse. But we also need to understand those individual factors that affect treatment outcomes, such as individual motivation to reduce alcohol. We know that motivation is a process that initiates, guides, and maintains goal-oriented behaviors. And the domains of motivation can be measured either by measuring the stage of change, their readiness to change, or readiness for treatment. So we provided these subjects with the intervention, but we do not know whether they are ready to receive it, and even when they received it, whether they are ready to change. And change is a difficult process, and Prochaska described change as a cyclic process, in that subjects at one time they are pre-contemplating about changing the alcohol, then they contemplate, they prepare themselves to reduce their habits, then they sometimes act on it and maintain their not using alcohol, and they keep moving along, and this cycle keeps repeating once in a while. So we realize that it is important to assess motivation to reduce alcohol use. But there are no tools that can help us to assess this. One tool, the stages of change, readiness, and treatment eagerness scale, is one of the best tools. There are others. There is the Eureka. There is just the motivational ruler, where you ask somebody from a scale of 1 to 10, how ready are you to change your alcohol use? But this tool has 19 items, and it captures client motivation on whether they recognize the alcohol use as a problem, whether what is their level of ambivalence, and the steps they've taken to reduce alcohol use. And we believe this tool could help clinicians providing relevant information for a subject at a particular stage of their change process. So we assess the reliability, validity, and factor structure of that tool, the stages of change, readiness, and treatment eagerness scale. It's version 8 in the population in Kampala, Uganda. This tool was designed in the US and it's been used in populations out there. There's been very little work, detailed work on trying to assess motivation in this setting. So we try to ascertain the appropriate factor structure of that tool in this population and assess its reliability and validity in our population here. And we compared the data from this population with the two known factor structures of this model. And we found that the data from this population does not fit any of the described models for this, so which means that we have to have a locally relevant structure to use to assess the stages of change if we are to design any effective intervention as we go along. So the tool, I say it's 19 items. There are very many questions like, I really want to change my drinking. So you have 5 scales, strongly agree and to strongly disagree, and in between, so we score you from there. So things like, I am an alcoholic, I am working hard to change my drinking, and so those are the questions in the 19-item tool. So in our data, we found a 2-factor model with an item response variance in factor 1 of 67 and 23 in the second one. Remember, the original tool has a 3-factor model. And how reliable was what was the reliability of our tool? The reliability between the 2 factors was 0.39, which we thought was good. And we looked at the internal consistency of the 2 factors, and they scored highly, 0.98 and 0.83. And that is about reliability, but is the tool valid? So the way the tool scored on readiness to change, we looked at how this, the higher the score, which means, rather the lower the score, which means the less likely you are to change your alcohol, should correspond to drinking more alcohol. And we see that concurrent validity there, which is one of the measures of validity, appears to suggest that the way our tool and the way we divided the 2 factors appears to measure what we intended it to measure. So we found a 17-item 2-factor model that did not have, I told you in the beginning that the tool is supposed to capture 3 domains: ambivalence, ambivalence to reducing alcohol use, recognition, and taking steps to reduce alcohol use. However, ours was a 2-factor model, and we need to have to undertake studies to confirm this in our population. So overall summary, more than half of the 30% people who are reported using alcohol took alcohol that was higher than the lower risk limits, and alcohol misuse among people infected with HIV was associated with self-reported medication non-adherence, non-disclosure of HIV positive status to sexual partners, as well as engaging in risky sexual behaviors among male participants, but not among female participants. However, we found that hazardous alcohol use was not associated with having lower CD4 cell counts, although in our sub-analysis, which I told you we're still exploring, participants with hazardous alcohol use and reported less than 95% adherence who had lower CD4 cell counts. However, we had not powered our study to test this. And adding a motivation intervention session onto the routine standardized post-intervention counseling session did not result in greater reductions in alcohol use over and above that was provided by the standard counseling alone. And the evaluation of readiness to change using the Socrates tool in this setting identified a 2-factor model. Of course, our study has several limitations. One, all along I was telling you alcohol use by self-report, and you're asking yourself, these people would want, probably they do not remember, they are good people, they just forgot. But we try to use another way in which to inquire about alcohol use, the timeline follow-back approach, where we ask in the last 30 days on each day whether you took alcohol. This tries to help the subjects remember, but also limited our interviews to 6 months, which we thought is a good enough time for somebody to remember. But that is if they've forgotten. But they could also want to not be seen to be taking alcohol, yet they are on ARVs, they are in care. And we provided enough training to our clinic, to our research assistants, and assured the confidentiality. But I wouldn't worry so much about social desirability bias, because we see that alcohol use report is high. It is very unlikely that you can come, the median age was 39, very unlikely that you would say you drink alcohol when you don't drink. If we're talking about campusers, maybe yes, but that one, very unlikely. So the estimates I provide a least likely estimate. So in fact, the problem could be worse. So if I'm saying it's already bad, so it cannot be worse. So at least the results can be interpreted with that in mind. And secondly, using the interview is better for scalability. If you're encouraging clinics to assess alcohol use. If you had used a biomarker, this is not easily scalable. But of course, there are biomarkers, which was our goal initially. However, logistical challenges and non-availability of liquid chromatography labs that provide our tests limited that. Some of our objectives looked at associations. We need to remember that associations are not necessarily causal, and even where we had a cohort study, we need to know that reverse causality could also occur. But the remedy here was, for example, subjects who had lower CD4 counts were more likely to take alcohol. We used a cohort study in objective to try and take away this limitation. I talked about assessment reactivity in that the more interviews you have, the more likelihood you will report reduction of alcohol use, so we have to take that in mind. And we are not able to undertake process evaluations for the interventions. However, we provided manuals and standard operating procedures. So in conclusion, alcohol use among HIV-infected persons was associated with negative behaviors, but did not have a significant impact on immunological response immunological response as measured by CD4 cell counts. In the interim, we think provision of standard positive prevention counseling to persons with alcohol misuse should be undertaken and provided at least once every 3 months. So we recommend designing innovative interventions, probably that could reduce alcohol use and other social behaviors. And we think using objective markers could be a slight improvement. And then, although our motivation was these repeated interventions once every month are not scalable, but it appears that it's not feasible to provide an intervention once every 6 months. And also the effects we observed among females, so other trials could need to stratify on gene and have enough numbers to look out for this apparent effect among females only. We think that clinic HIV care providers should develop protocols to routinely assess alcohol and co-occurrence of other negative behaviors. And we also believe that subjects who have been assessed to take alcohol that is higher than the lower risk limits, these participants should be provided with the available intervention. This intervention is available, however, its administration is not well structured. The idea is it should be received every 6 months, but the practice is slightly different. And there are some recommendations to improve on the research. For example, our intervention was based on motivation intervention. So probably we could motivate the subjects to reduce the alcohol, but also add in cognitive behavior therapy, which involves tackling the thinking behind the alcohol, in that probably a mixed theory intervention will provide an effective intervention than just a one theory-based intervention. And then I talked about booster doses of intervention sessions, and then using objective markers, which was one of our goals initially, but we failed because of logistics. And we only did an exploratory factor analysis, which of course needs to be confirmed in a similar population. And yeah, that's. I do not have policy recommendations from this research. However, it will be unfair for most of us here to talk about alcohol use and forget the setting within which the study was undertaken. So using published work, newspaper work, media, and everything, I think we need to incorporate strategies to reduce alcohol to reduce alcohol use. For example, when you look at the National HIV Prevention Strategy, it is so silent on the impact of alcohol use on HIV transmission. So incorporating such in our National HIV Prevention Strategy would be important. And also, at the moment, we do not have a strong, every time we hear a strong alcohol prevention policy. So I think it is time this was worked on to try and strengthen the setting within which the population that we serve live. But I want you to note that this is based on my scholarly reading, not from my research. So I want to thank the study participants, the study team personnel, both from the IDI and the other staff that helped us, and my supervisors for helping me along the way. PhD fellows from the School of Public Health, the Thrive PhD fellows, Mepi Mesau and Carter. I'm grateful to the Thrive Secretariat for all the assistance and administrative support they gave to me, and funding from Wellcome Trust that was administered through Thrive. And additional funding was obtained from the Department of Population Health Sciences at the University of Wisconsin through my supervisor to have protected time in Madison. And the Infectious Disease Institute, of course, provided generous funding in terms of space and salary support to some study staff. And most importantly, my family for the support. Thank you very much.